My name is Srdan Verstovsek. I am the staff physician in the Leukemia department at MD Anderson Cancer Center in Houston, Texas. This is a part 2 of a presentation on the eosinophilic disorders, classification, diagnosis, and treatment. We learned a lot so far from Dr. Gottlieb about hypereosinophilic syndrome. And we learned that some patients with hypereosinophilic syndrome actually have FIP1L1 PDGFR alpha abnormality, and that they can be classified as a group on its own. So the next question is, how many patients actually are there with hypereosinophilic syndrome, and how many of them may have these molecular abnormalities? It is estimated from the literature, because there is no registry of these patients, and nobody has a very large group of patients followed for a very long time. So the only source of information to answer this question is from a review of the literature. It is estimated that there are about 5,000 cases annually in the United States that may have hypereosinophilic syndrome. Again, from the past experience, from the literature, it is believed that about 80% of these patients will be alive and well after 5 years of a follow-up, but that percentage decrease over time to about 42% at 10 and 15 years after initial diagnosis. Among these 5,000 cases, minority, but still a substantial group, will have a FIP1L1 PDGFR alpha abnormality, as indicated on this slide. So this is now having an impact on a number of overall patients that we identify as having idiopathic HES. We are, in a way, dissecting patients with HES by discovering molecular or cytogenetic, which are chromosomal abnormalities, in selected patients and making them more uniform and identifying subgroups among HES patients, which is presented on this slide. So idiopathic HES can now be divided into a group of patients with PDGFR alpha abnormality, in a group of lymphocyte variant hypereosinophilia, and the rest of yet unknown molecular abnormality, so-called idiopathic HES. As the advance in science is implemented into analysis of samples from patients with HES, these subclassifications will take more and more effect. And one evidence of that scientific approach to a discovery of abnormalities in samples from patients who are believed to have HES is presented here. This is rather confusing, but here we have a list of a number of genes and abnormalities in chromosomes that are identified in different patients with HES. In the top part, within each square or circle, is the name of the gene. Like in the middle, there is PDGFR alpha identified in a gray circle. In the same circle, there is a 4q12 abnormality. This means this gene is on a 4th chromosome Q12 position. So each gene here is now identified in particular spot on the chromosome, and we know that there are abnormalities that can be combined. These are lines that connect different genes, and application of our scientific methods will help us dissect patients with HES in subgroups based on molecular abnormalities as we go forward. Some of this knowledge is already in place in current World Health Organization classification scheme for myeloid neoplasms. This is the official classification used by pathologists and practicing oncologist hematologists at the present. And here is a current scheme. In the upper part is acute myeloid leukemia as a representative of acute diseases. Majority of the slide is populated with chronic diseases, which are divided in several groups. As you can see, chronic diseases include myelodysplastic syndromes / myeloproliferative neoplasms. This is abbreviated here as MDS/MPN. Then number 3 is myeloproliferative neoplasms in the middle of the slide that are divided further in chronic myeloid leukemia, then polycythemia vera, essential thrombocythemia, primary myelofibrosis. This is all on the right side of the slide. And further on to chronic neutrophilic leukemia, chronic eosinophilic leukemia, and hypereosinophilic syndrome, and others. You see, the chronic eosinophilic leukemia and hypereosinophilic syndrome are subclasses of myeloproliferative neoplasms. In this title, myeloid stands for bone marrow cells. Proliferative obviously means that cells grow without control, and neoplasms means that they are actually abnormal, all originating from one cell and growing without control. At the bottom is a new group of diseases that are now called myeloproliferative neoplasms associated with eosinophilia and abnormalities of PDGFR alpha, PDGFR beta, or FGFR1. What is this? These are myeloproliferative neoplasms that present with the patients having high percent of eosinophils in blood and bone marrow and having certain abnormalities in genes that are listed here. 3 genes that have been identified so far. We talked a lot about PDGFR alpha, but there are others, PDGFR beta and FGFR1, very rare. But now we can subdivide these patients in these 3 groups based on presence of these genetic molecular abnormalities. These are acquired abnormalities, not inherited, to be clear. Okay, so quite a few things have changed over the last few years with identification of these molecular abnormalities and institution of the new therapies. So let's review how we make diagnosis of hypereosinophilic syndrome today. We start obviously looking at the patient and looking at clinical signs and symptoms that patient may have. And here we have listed some constitutional symptoms that are seen in patients with HES, some symptoms related to the skin, and then non-specific symptoms of other types like cough, dyspnea, diarrhea, and others. Some patients, unfortunately, may have signs of organ involvement, meaning the heart function may be affected, the liver function may be affected, the bone marrow function may be affected, and patients have, for example, anemia. Once we see that, we go to step 2. We look at the peripheral blood. Then we do the bone marrow biopsy and aspiration. And we talked about this quite a bit in prior presentation by Dr. Gottlieb. We look at blood to look at percent of eosinophils, blasts, which are early baby leukemia cells. We look at other helpful measurements like a serum B12 and serum tryptase, which are protein in blood, sometimes high, as related to high percent of eosinophils. Bone marrow examination is mandatory to make sure that we are talking about disease related to eosinophils and they are not related to other bone marrow disease that can boost their growth or to some benign conditions that were discussed in the first presentation. Once we determine that the patient has a disease of the bone marrow, we would strongly suggest additional testing on chromosomes. And an example of a chromosomal analysis is shown in upper right corner. These are finger-like structures that carry genes. It is done usually as a part of the bone marrow biopsy and aspiration evaluation. A sample is sent to the laboratory where the cells are grown in a culture, and under the powerful microscope, one can look at the chromosome inside the cells. The first point here is to exclude the presence of abnormalities in chromosome 9 and 22, which is called so-called Philadelphia chromosome. If it's present, this is chronic myeloid leukemia disease. If it's absent, it just makes one certain it's not chronic myeloid leukemia, but it doesn't provide any additional information. Additional information is done by doing FISH, previously discussed. This is fluorescence in situ hybridization, abbreviated as FISH, where the cells are grown in the culture and certain fluorescent probes are added and they stick to chromosomes. In this particular example, these fluorescent probes stick to genes on chromosome 4, and we have yellow, green, and red present on one chromosome on the picture on the right lower corner. This is a normal chromosome 4 having all 4 colors present. And then we have another chromosome without the green color. This green color is supposed to be going and attaching to a gene CHIK2, which is deleted, and this is indirect positive signal for abnormalities in PDGFR alpha, as explained in previous talk. So chromosomal testing, looking at chromosomes themselves, and FISH testing for abnormalities in PDGFR alpha are vital tests for proper analysis of a case of possible hypereosinophilic syndrome. It is important to highlight that PDGFR alpha abnormality on chromosome 4 cannot be seen by normal cytogenetic abnormality analysis like a Philadelphia chromosome. Finally, one would like to confirm these findings so far by doing the molecular testing. Even in cases of FISH test being negative for PDGFR alpha, molecular testing for PDGFR alpha at the genetic level is useful, and it may eventually show positivity. The reason is not all tests are foolproof, and they may be sometimes wrongly negative. I'm not going to explain this test in much more detail, just to say that this is molecular testing, genetic testing for abnormalities in PDGFR alpha, and it can determine precisely the abnormalities in PDGFR alpha if it's present there, and it's useful for monitoring the response to therapy, as the therapy for these patients with this abnormality is very effective and eliminates disease completely, and therefore molecular testing in patients on therapy is useful to do. Now, what are the potential targets for therapy of hypereosinophilic syndrome? We talked about therapy with imatinib, also known as Gleevec, for patients with PDGFR alpha abnormality. This is outlined in the lower part of the slide. What we see here is eosinophil with abnormalities of interest outlined. So PDGFR alpha is one. However, there are other proteins on the surface of the cell. Here we have IL-5R. This means interleukin-5 receptor. Interleukin-5 is a protein that goes around the blood. It attaches itself to a receptor for interleukin-5 on the surface of eosinophils and boosts the growth and survival of eosinophils. And then there is a CD52 protein on the surface of eosinophils outlined on the right side of the cell, which is a protein for which we do not know a real function, but it's present on the surface of eosinophils, and we can use a medication called Campact, an antibody that attaches itself to it. and kill cells that have CD52 on the surface. I'll explain this in much more detail later. So let's talk first about Mepolizumab. This is the antibody, a protein that inhibits interleukin-5 binding to the interleukin-5 receptor. This is how it works. You see the green triangle comes and blocks the binding of interleukin-5 to its receptor on eosinophils. As I said, interleukin-5 is responsible for the growth, activation, and survival of eosinophils, and if you inhibit interleukin-5, it may actually lead to a death of eosinophils. So Mepolizumab was tested in a clinical setting in patients with hypereosinophilic syndrome, and here is a summary of initial result in about 15 patients where Mepolizumab therapy was able to lower eosinophils in blood and tissues. This medication is given IV monthly, and a large international study was recently done that evaluated this medication as a possible therapy for hypereosinophilic syndrome patients. This was a randomized, double-blind, placebo-controlled study. The design of the study is outlined here for detailed information. The patients were required to be on prednisone, which is usual standard first-line therapy for hypereosinophilic patients, and be on prednisone at the high doses of 20 to 60 milligrams a day with good control of the disease. And then the patients were randomized to Mepolizumab or placebo, and the aim was to see whether we can eliminate the need for prednisone over 9 months by replacing it basically with Mepolizumab. And the reason is long-term prednisone use has many significant side effects. So one would like to replace it with a safe drug like Mepolizumab. Primary objective was therefore achievement and maintenance of a significantly reduced prednisone dose with a good control of the disease. As you see, results in the last bullet, 84% of patients on Mepolizumab were able to taper prednisone versus 43% on placebo. The drug is not approved yet, but it's accessible through compassionate use program by the manufacturer. Now, the other medication that I mentioned briefly is Campad. It's another monoclonal antibody, and here we have a structure. This is how it looks in real. It's a protein that binds to another protein called CD52 on the surface of the eosinophils. It is present on lymphocytes, another type of white cells in blood, and CD52 is expressed on cells that are lymphoma cells and acute lymphoid leukemia or chronic lymphoid leukemia. In fact, Campad is approved as therapy for chronic lymphocytic leukemia. This is how it works. So in orange, we have Campad. It comes to the cell that has CD52 attached to it and kills the cell. So it's a different mechanism of action from other therapeutic agents. Here is an example of a use of Campad in a 69-year-old gentleman who had a number of symptoms related to uncontrolled disease. This is a different setting than what I described for Mepolizumab. This patient had a lot of problems. He was on prednisone without the good control of the disease, very high white cell count and a lot of eosinophils. And then Campad was given. Now, this is given 3 times a week IV for about a month. That's a standard therapy for chronic lymphocytic leukemia, so the same dose and schedule was applied to this patient with eosinophilia. As you see, there was a rapid normalization of white cells and eosinophils and elimination of symptoms and signs of hypereosinophilia, but the patient relapsed after 6 weeks because the therapy was not given more than for a month. With institution of the maintenance therapy, occasional injections of Campad as needed, the patient is now symptom and signs-free for about 3.5 years. This is an example of what happens in patients with hypereosinophilic syndrome that are treated with Alemtuzumab. On the upper part, we have Alemtuzumab. This is a Campad. Dose is listed. And the route, how it was given. IV means intravenous, and sub-Q or SC means under the skin It can be given under the skin too. And in the red line, we have percent of eosinophils that go down significantly, very rapidly, and in green, a total number of white cells. So it's very effective therapy in a short order. This is how the bone marrow looks in typical patient with hypereosinophilic syndrome. All these reddish cells that we see here are precursors of eosinophils in bone marrow. After therapy, this is what we see, elimination of these cells. This is a clinical picture of the patient before therapy and after therapy with Alemtuzumab. As you see, the rash, the swelling of the body rapidly improved. This is within few weeks. Here we have an examples of hands of this patient that were swollen with the blisters. Patient was actually not able to eat on his own using his hands, had to be fed by his wife, and this resolved within few weeks. Since then, the number of patients treated with Campat has increased. This is a summary of 11 patients so far. As you can see, bullet number 3 tells us that complete hematological response, which means normalization of the blood cell count, was achieved in 10 patients out of 11 within 2 weeks. Bone marrow also normalized, but this medication does not really eliminate disease. It eliminates eosinophils, but not the cause for their growth. So it has to be given occasionally to maintain patients in complete hematological response. If everything else fails, there are attempts to see what else can we do to eliminate disease, because most of the therapies that we are using in the community setting are palliative. They control the disease signs and symptoms, but do not eliminate disease. And here is an example of intensive chemotherapy, which is really a last resort. The bone marrow transplant is a last resort as well. Now here we have two medications, cladribine and cytarabine, which are given IV. They are also used for acute myeloid leukemia therapy. And they were used in these 9 patients with hypereosinophilic syndrome. And they were able to achieve complete remission. That is the last bullet on the slide. 5 patients had complete response, meaning elimination of the disease, no signs or symptoms, and normal bone marrow, but patients did relapse and didn't live too long. So, again, maintenance therapy might have had benefit, but was not provided. And in the future, if this kind of intensive therapy is needed, it needs to be given more than once. So we reviewed some of the possible new therapies, but how do we treat really patients? We start first by proper evaluation, as we said before. We determine that the patient has hypereosinophilic syndrome, and then we do FISH test for CHIK2 or molecular study that we explained in detail before, and we try to determine whether the patient has PDGFR alpha abnormality. That would mean CHIK2 positive is a surrogate marker for PDGFR alpha abnormality on the left side of the slide. And in this case, the patient would be treated with Glivec, 100 milligrams a day, very low dose. Everybody who has hypereosinophilic syndrome with CHIK2 positivity, which indirectly means that the patient has PDGFR alpha abnormality, or the molecular test for PDGFR alpha is done, and the molecular test is positive for PDGFR alpha abnormality. Either test is fine. In these cases, if the tests are positive, patients should be treated with Glivec because it does eliminate disease very quickly in almost everybody. If the patient has negative test for PDGFR alpha abnormality, which would be CHIK2 negative test on this slide, on the right side, then the approach needs to be individualized. If the patient has symptoms, we have perhaps evidence of organ damage, or the eosinophils are very high in blood, yes, the patient would benefit from therapy. We can treat patients with interferon, prednisone, hydroxyurea, Glivec also, but at a higher dose, 400 milligrams a day, or patient may join a clinical study. First line of therapy usually is prednisone. If patient is asymptomatic, has no signs and symptoms of the disease, many are satisfied with the close observation without the therapy. Now we can look at this same issue in a different way. We can start by answering the question, what is the first-line therapy, what is the second-line therapy? And here we summarize this in a way. In the upper part of the slide, we clearly say that corticosteroids, which is a prednisone by mouth, usually are the first line. They are very effective in reducing eosinophil count and possibly limit organ damage with that. If that's not possible, hydroxyurea is commonly used as a first-line cytotoxic agent. Glivec is a possibility, certainly a first line for patients with PDGFR alpha fusion or abnormality, but it's also a possible therapy for patients with PDGFR alpha negative test. Second line therapy, other cytotoxic agents as listed. Interferon can be used, or if everything else fails, as I mentioned before, allogeneic stem cell transplantation, which means bone marrow transplantation, or intensive chemotherapy, as mentioned before. These are all more of a investigational attempts in nature because the number of patients so far that did undergo a bone marrow transplant for HES is very small. Another look at the treatment options for patients with hypereosinophilic syndrome can be based on what type of HES patient has. If the patients have PDGFR alpha abnormality one more time, the patient would be treated definitely with imatinib or Glivec. If the patient has chronic eosinophilic leukemia, which is usually a little bit more aggressive than hypereosinophilic syndrome, chemotherapeutic agents like hydroxyurea may be necessary. Interferon is a possibility. Imatinib, clinical trial. In case of lymphocyte variant of hypereosinophilic syndrome, which are usually related to immunological disbalance in the patient, some prednisone or immunosuppressive agents or anti-interleukin-5 antibody, mentioned Mepolizumab, are options. In typical idiopathic hypereosinophilic syndrome, again, prednisone, hydroxyurea, imatinib, and others are therapeutic options. Where do we go from here? Because of the continuous efforts to identify molecular abnormalities in patients with idiopathic hypereosinophilic syndrome, it is certainly easy to envision where further refinement of WHO classification will be undertaken based on those new findings. We should then be able perhaps to identify biological targets for therapy based on those abnormalities, like we are doing right now with imatinib as a first-line, very effective therapy for patients with PDGFR alpha abnormality. With this, I will conclude my presentation, and thank you very much.